of modern medicine. Welcome back to the deep dive. Today we are stripping away all the high-tech machinery of modern medicine, the MRIs, the labs, the AI diagnostics, and going back to the absolute bedrock of clinical practice. We are talking about the detective work that happens before a needle ever even touches skin.
It's interesting you call it detective work because that is exactly what it is. I think there's this misconception that medicine is all about, fixing the problem with a procedure or a pill.
Right.
But you can't fix it if you don't know what it is. And here's a statistic that usually blows students' minds. 80 to 90% of the time, the diagnosis doesn't come from a scan.
Yeah.
It comes from the history.
That's a massive number. It suggests that if you aren't listening correctly or looking closely enough in those first few minutes, you're essentially flying blind.
You are.
So we have a stack of lecture notes, checklists, clinical guides here that break down the art of the medical history and the general survey. The mission today is to figure out how to transform these kind of dry checklists into a three-dimensional understanding of a human being.
Right. We want to move from just filling out forms to gathering evidence. Because if you miss a clue in the social history or you misinterpret a visual cue when you walk in the room, the consequences can be, well, it can be fatal.
Let's start right there at the threshold. The source material calls this the general survey, or the across-the-room assessment. It's that immediate data intake.
It is.
And I was struck by the idea that the exam begins the second you see the patient.
It has to, because people, they change their behavior once this formal interview starts.
Yeah.
They sit up straighter, they try to answer correctly. But that across-the-room moment, that's raw data.
So what are you looking for?
The immediate visuals, appearance, behavior, and safety.
Okay, so the notes mention checking if the patient appears their stated age and gender. That seems standard. But then it gets into hygiene and dress. This is where it feels like we walk a fine line between clinical observation and judgment.
It does, and you have to be careful. It's about context and deviation from the norm. I mean, if someone is wearing a wrinkled shirt, that's just style.
Sure.
But if there is a distinct odor of urine, or if they're wearing a heavy parka and it's 90 degrees outside, that's clinical data. The inappropriate dress for the climate is a classic alarm bell.
So it makes you ask questions.
It forces you to ask, is this a thyroid issue, regulating their temperature poorly? Or is this a psychiatric issue where they've lost the ability to judge social or environmental norms?
So you're processing metabolism and mental health just from a coat.
Exactly. And you're looking at body type. We scan for the extremes. Is the patient emaciated or experiencing muscle wasting? That points to chronic illness, maybe cancer, maybe malnutrition.
And on the other side?
On the flip side, are they obese? And if so, how is that weight distributed? It just sets your baseline for what systems might be under stress.
Movement is another big one listed here. Gait.
Huge. Absolutely huge. If they shuffle, are we looking at Parkinson's? If they're dragging one foot, that unilateral weakness, did they have a stroke 3 years ago? Or are they having one right now?
And you have to process that before you even say hello.
Before a word is spoken.
The material groups distress and level of consciousness together. Distress seems like it would be loud, someone screaming in pain.
Sometimes. But the quiet distress is often more dangerous. Are they tripoding?
That's sitting on the edge of the bed, leaning forward, hands on.
on knees, right. They do that to physically expand the chest cavity because they can't get enough air. That is a patient in respiratory failure, even if they aren't making a sound.
Wow.
Or look at the level of consciousness spectrum. We want awake, but if they're lethargic, kind of drifting off or obtunded, where you have to shake them to get a response, that's a brain that is shutting down.
And once they are awake, we check mental status. The gold standard here is oriented times 4. I've seen this on charts, but let's decode it.
It's the hierarchy of brain function.
So, person.
Person. Do you know who you are? That's usually the last thing to go. Then place and time, which represent memory and orientation.
Oh.
And the fourth is situation. Do you know why you are here?
That one tests insight.
It does. If a patient knows it's 2024 and they are in a hospital, but they think they're there because the CIA is tracking them, well, they are oriented times 4.
Okay. To really drive this home, the source material provides these contrasting case studies. It's almost like a spot the difference game, but for clinicians. I want to read the raw data on Mr. Jones first.
Okay, let's break him down.
Mr. Jones is elderly, looks pale and chronically ill, alert, good eye contact, but unable to speak more than 2 or 3 words at a time due to shortness of breath. Intercostal muscle retraction when breathing, sits upright in bed, thin with diffuse muscle wasting.
Okay, so this is a classic fast patient. The investigation needs to move very quickly. The intercostal retraction, that's the skin sucking in between the ribs, that means his body is fighting for every single breath. The two-word dyspnea, his inability to speak full sentences, tells me his oxygen exchange is critical.
And the muscle wasting?
It suggests this isn't new. He's likely a COPD patient or has end-stage heart failure. I'm already calling for respiratory support before I've even asked him his name.
Wow. Okay, now contrast that with Miss Smith. Young woman, disheveled appearance, wearing a t-shirt with a tear in the neckline and shorts soiled with a brown-colored liquid, sitting in the exam chair, alert, oriented, but crying and will not make eye contact.
See, visually, this is a completely different emergency.
How so?
The brown liquid is highly specific. Is it blood? Is it stool? It implies a loss of bodily function or a significant trauma. The tear in the neckline combined with the crying and lack of eye contact just screams potential assault or acute psychiatric crisis.
So two totally different paths.
Completely. Mr. Jones needs oxygen. Ms. Smith needs a safe environment and a very gentle, likely forensic approach. The general survey just dictated two diverging paths instantly.
It's amazing how much narrative is in just those visual descriptions. Once we've established that baseline, we have to talk to them. We need the chief complaint.
To see.
There's a note here that says, simply, current issue only. And there's a little comic of a nurse saying, I asked for your chief complaint, not your life story. Is it really that hard to keep patients on track?
It is the hardest part of the interview. You ask, what brings you in? And they start with, well, in 1987, I fell off a ladder. And you have to gently steer them back.
Right.
We need to know what made you walk through the door today. Is it chest pain? Is it a medication refill? A work physical?
And once they give you that symptom, let's say it's pain, we have to drill down. The source gives us a mnemonic, old carts.
It's the standard for symptom analysis. You
Oh,
can't
no.
just write patient has pain. You need the dimensions of the pain.
Okay, let's run through it.
Okay.
O is for onset.
When did it start? But more importantly, what were you doing when it started? Did the back pain start while you were lifting a fridge, or did it wake you up from sleep? Those point to very different causes.
L is location. D is duration.
Be specific. Does it last 5 minutes? 5 hours? Is it constant?
C is for character. This is one where I feel like patients probably struggle for words.
They do. They'll just say, it hurts.
Yeah.
You have to offer them descriptors. Is it sharp? Dull? Crushing? Burning?
And those words matter.
They matter a lot. Burning often means nerve pain or reflux. Crying often means cardiac. Sharp might be muscular or pleural.
Okay, A is for aggravating and alleviating factors.
What makes it better or worse? If chest pain gets worse when you take a deep breath, it's probably not your heart. It's likely your lungs or ribs. That distinction saves you $1 million workup.
R is radiation.
Does the pain travel? We all know the cliche of arm pain and a heart attack. Gallbladders often refer pain to the right shoulder blade. Kidney stones radiate to the groin. The body's wiring is weird, and radiation helps us map it.
And finally, T is timing, and S is severity.
Severity is that 1 to 10 scale. It's subjective, sure, but it gives us a trend. If you came in at a 9 and now you're at a 4, we're winning.
The source material does add a big caveat here about critical thinking. It says, don't be a robot.
Right. I mean, if a patient comes in for a medication refill, don't ask them about the radiation of their empty pill bottle.
That's right.
Use the tool where it fits. Old carts is for symptoms, not administrative tasks.
So we've assessed the room, analyzed the main complaint. Now we broaden the scope, the history, proper, medical, surgical, family, and personal.
This is a background check.
Under medical surgical, it lists the usual suspects, hypertension, diabetes, COPD. But under surgical, it specifically calls out implants, pacemakers, infusion ports, spinal stimulators. Why the focus on hardware?
Because hardware changes the rules of engagement. If you have a pacemaker, I can't put you in an MRI machine. The magnet will rip it out or shut it off.
Oh, wow.
If you have a spinal simulator for pain, we need to know before we try a lumbar puncture. And infusion ports, those little discs under the skin for chemo, are major infection risks. Patients often forget to mention them.
Then there's family history. We're looking for genetic loading here, heart disease, cancer. The notes mention a sensitivity check. History may be unknown if adopted.
That's vital. Nothing alienates a patient faster than a clinician pushing for family history when the patient is adopted or estranged. You ask, you accept unknown, and you document it. Simple as that.
Personal history covers lifestyle, diet, exercise, sleep, and employment. I think we often overlook work as a health factor, but the notes are specific about occupational hazards and shift work.
Work is where you spend a third of your life. If you're a coal miner, I'm worried about your lungs. If you're a nurse doing night shifts, well, that's a carcinogen.
Really?
The World Health Organization actually lists shift work as a probable carcinogen because it disrupts circadian rhythms and cortisol so badly. It also drives hypertension. So asking, what do you do, isn't small talk, it's risk assessment.
That brings us to the section that I suspect causes the most awkward pauses in the exam room, the social history, or what I'm calling the vice squad.
The fun stuff.
Yeah.
Smoking, drinking, drugs.
The key takeaway from the source here seems to be specific. For smoking, it's not enough to ask, do you smoke?
Not anymore. No. You have to ask about vapes, e-cigs, hookahs, cigars, and you have to quantify it into pack years. 1 pack a day for 20 years is a 20-pack-year history. That number helps us predict the likelihood of COPD or lung cancer. Some is not a number we can use.
And for alcohol, the notes even list tall boys and liters.
This is a detail I love because it's so real.
Yeah.
If a patient says, I have 2 beers a night, you might think that's fine. But if those 2 beers are 24-ounce tall boys with 8% alcohol, that's the equivalent of a 6-pack of light beer.
So you have to do the math.
We have to do the math to understand the liver toxicity.
There's a bold all-caps warning in the notes for both alcohol and drugs. Last use. Why is the exact time of the last drink or dose so critical?
Withdrawal. This is a safety issue for the entire hospital. Alcohol withdrawal delirium tremens can kill you. Usually kicks in 48 to 72 hours after the last drink.
I see.
So if I know your last drink was this morning, I have a clock in my head. I know when to expect the seizures or hallucinations, and I can medicate you prophylactically. If I don't ask and you start seizing 2 days later, that's on me.
Okay, so same logic for drugs. The list here is extensive. Cocaine, heroin, meth, Molly, GHB.
Same logic. And with drugs, we also need the route. Are you swallowing it, smoking it, or shooting it IV? 4V drug use introduces a whole new set of killers. Endocarditis, hepatitis C, HIV.
So if a patient says they use heroin,
My next question has to be, do you use needles? It's blunt, but it is absolutely necessary.
we're almost through the investigation. We've done the habits. Now, medications and allergies. This seems straightforward, but the notes highlight a specific frustration. The little yellow pill.
The bane of every clinician's existence. I take the little yellow pill for my heart. Well, that could be anything. We need the name, dosage, frequency, and route. And we have to act like detectives to get it, calling their pharmacy, looking at old records.
And it says to include herbals and supplements. Do those actually matter?
Hugely. Just because it's natural doesn't mean it's chemically inert. St. John's wort interacts with blood thinners and antidepressants. Ginkgo biloba increases bleeding risk. If you're going into surgery taking massive doses of garlic, you might bleed out on the table. We need to know.
That segues right into allergies. The source makes a distinction between an allergy and an intolerance.
This is a crucial distinction. If you take codeine and you throw up, that's a side effect. It's an intolerance.
Okay.
If you take codeine and your throat closes shut and you stop breathing, that's an allergy. We treat those very, very differently. We can manage nausea. We can't easily manage anaphylaxis.
The notes list the big 8 for food allergies. Fish, shellfish, peanuts, tree nuts,
Yeah.
and then environmental stuff like latex.
Latex is a big one for us because hospitals are full of it. Gloves, tubing, catheters. If you have a latex allergy, we have to strip the room. And iodine matters for CT scans because the contrast dye is iodine-based.
Okay, we have reached the final safety net, the review of systems, or ROS. In my experience, this is usually a form with a million tiny check boxes that I frantically fill out in the waiting room.
That is the patient experience, yes. For the clinician, the ROS is the catch-all.
How does it differ from the history we just took?
The history is the story you tell me. I'm here for a cough. The ROS is the interrogation for what you forgot or what you didn't think was related. It's a head-to-toe scan.
Okay, so let's look at some categories. General, weight change, fever, night sweats, heat, vision changes, ringing ears, nosebleeds, respiratory cardiac, wheezing, chest pain, and swelling feet. Wait, why is swelling feet under cardiac?
Edema, or swelling, is often a sign of heart failure. The heart isn't pumping effectively, so fluid backs up in the legs. A patient might think their shoes are just tight, but the ROS tells us their heart is failing.
That's a great catch. Okay, then we have GIGU, heartburn, blood in urine, and psychiatric. Depression, sleep. The rule here is, if they check the box, you must assess.
No exceptions. If you come in for a sprained ankle, but you check the box for blood in urine, I cannot ignore that. You could be bladder cancer. The ROS is designed to catch these silent pathologies that the chief complaint missed.
It ensures we are treating the whole person.
Not just the ankle. Exactly.
It's impressive when you lay it all out like this. You realize that a standard checkup is actually a highly structured data mining operation. We've gone from the visual cues of the general survey, through old carts, dug into the genetics, confronted the social habits, reconciled the meds, and finally swept the whole body with the ROS.
It is a puzzle. And the stakes are the patient's life. The general survey tells you how fast to move, the history tells you where to look, and the ROS catches what falls through the cracks.
It transforms the patient from just a symptom into a complex biography.
Precisely. And that accuracy sets the trajectory for every single treatment that follows.
So we've covered a lot of ground today. What is the one thing, the final thought you want our listeners to take away from this whole investigation?
We've spent all this time talking about questions, what to ask, what to look for, what boxes to check. But the most sophisticated tool a clinician has isn't on a checklist. It's the ability to listen to the silence.
The silence.
When you are going through these histories, pay attention to what the patient is not telling you. The pause before they answer about alcohol. The fact that they skip the section on supplements. The reluctance to make eye contact when you're discussing home safety. A good clinician listens to the answers. A master clinician listens to the silence just as closely. That is where the real diagnosis often hides.
That puts the detective role in a whole new light. It's not just about evidence, it's about intuition.
It is.
Thank you for guiding us through the evidence today. And thank you to everyone listening. Keep asking the hard questions, and we'll see you on the next deep dive.
Take care.